Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Hello everyone, this is Brigid Maloney.
Welcome back everyone, I'm obstetrician Dr. Patrick Maloney.
And today's episode is Who is in the room when you birth and why are they there? This is the episode that Pat thinks we don't need. But that's because you're in the room all the time.
I'm there.
So this is really what we hope you learn from this episode is it's a logistics episode, isn't it? It's about helping you visualise the day of your baby's birth and what to expect. Good. Yeah. We want to take out the surprises so you feel more comfortable on the day and you know why someone is in the room and you feel empowered to say, hey, what are you doing in here?
What are you doing here?
Does everybody in this room need to be in this room?
Yeah, that is a good point.
Yeah, and it may not be you, it might be your partner.
Yeah.
Yeah, or your support person or whoever's there with you. Mm-hmm. Yeah.
It can sometimes in the hospital it seems there's an awful lot of people there.
Yeah.
And ideally there's no just like interested members of the general public. Everyone should have a job if they're there.
Yeah, and sometimes it's worth knowing what that job is.
Yep.
So I think this is a good episode, Pat.
Perfect.
Yeah, good. All right, so I want to start with labouring at home because, you know, I hope it's come across in our episodes. You always recommend people to labour at home as long as they feel comfortable, don't you?
Yeah, so it should be part of everyone's birth plan if it's appropriate that some of the early parts of labour happens at home. Yeah. There's always exceptions to that rule for various reasons. Maybe you live way too far from your planned birthing hospital. But certainly at the start, for most people, there's no hurry. And we should have some of that early part of labour at home, which is decrease the amount of time in the hospital and may contribute to reduction in unnecessary interventions. Yeah.
And when you are labouring at home, it's your choice. You're choosing who's there.
Yes, that's a good point though. So this is something that we should plan for. You won't want a surprise.
No.
So who's going to be there in that early phase? Your partner, your sister, your mother?
Yeah. If you've got children already, like are they going to be there? Yeah. So, you know, what's the plan for your family? And I think that's important. You also might have a birth support person. So yes. You might have an independent midwife or a doula or someone like that. So, you know, they're people that you know are going to be there. In my second labour, I had my father-in-law and brother-in-law turn up unannounced. They didn't know I was going into labour, but that was they soon turned around and went somewhere else. But, you know, those sort of things, just keep planning. So that's your choice. Who's there when you're labouring at home?
Very good. And I think we should also have consideration of that those people need a job.
Yes.
Okay. They're not just there to hold our hands. So there's a job for people and that's what will make it work.
Yeah. No, that's absolutely a good point. So you've driven off to the hospital or got a taxi or however you got to the hospital.
Orange scooter, Uber.
You've arrived at the hospital. Who's the first person that you see?
Well, I think this is a good question because these are the practical things that they should cover in the hospital birthing classes or in the hospital intake meeting. What happens if you're coming in labour? So you should have a phone number to ring. You should have a phone number to get some expert advice. You should be told which door to come to. How to get to the labour ward, how to get in after hours. All those sort of things are really important. This is the practical nitty-gritty of coming to the hospital at night time in particular.
Yeah, which, you know, might happen frequently.
Yeah. Yeah. So there should be an easy way for you to get in and identify yourself as someone in labour to the person at the front door and then not be shunted in through a busy hospital emergency department but move straight up to birthing suite.
Okay, so you just, when you ring to say that you're in labour and you're coming in, they'll tell you those instructions.
Yeah, but it should be super clear. You've got enough on your mind without knowing how to get into the hospital at night time.
Yep. All right, and then you go into the labour and delivery room. Is that what it's called?
Sure.
Yep. And who's there with you then?
Well, I think that's where you need your team up and going. So is it our partner or support person, other family member, if you've got an independent midwife or a doula, has that person been fully arranged to come with you into the hospital? Everyone aware of their roles and responsibilities? And then, in particular, well before the day when the baby's coming, who's coming, who's going to be there?
Yeah. And then you would meet the midwife that's going to be allocated to you. Is that right?
Yeah, that's in our system. So you'll have a midwife allocated to you, and that midwife will stay with you and care for you at least until the baby comes, or at least until the end of their shift. And after that, another midwife will come on who, again, will be with you until the baby comes.
And we hear so many stories of midwives that stick around because the baby's close or whatever, even though their shift's ended.
Yeah, they do. Yeah. A little bit of that. That's very dedicated.
Very dedicated.
I think if we're fully dilated and pushing, then sometimes don't want to go home. Want to wait till a baby comes and see that.
And what if you don't get on with a midwife? Can you ask for a different midwife? No. I'm getting a shake of the head there.
I don't think so. When we talk about making birth plans, the thing that I ask all of my patients to put up the top of their birth plan is a little acknowledgement that even though this is what my plan is and these are my preferences, I understand that the birth process can be unpredictable and tricky. And I like them to put in a little nod to the expertise of the midwives who are looking after them in that opening paragraph of the birth plan. Because what that says to the midwife is, this is my first go. You've been here for hundreds or thousands of births, and I want to hear the benefit of your expertise. That's how to get off on the right foot. Yeah.
Yeah, and hopefully your hospital's perfectly resource allocated and you have a midwife that can spend some decent amount of time. But they would be caring for a few more people at the same time, wouldn't they?
Well, ideally, if you're in active labour, then just you.
Okay.
But what if it's a super busy day or a pandemic? So things are different.
Yeah. And in those sort of early labour, would you be seeing your obstetrician if you had one, say, in a public or a private sense?
Yeah, so this is where it gets a little different in public versus private, and we're talking about our system here in Australia. So in the public hospitals, you may not need the care of an obstetric doctor at all. You might come in to spontaneous labour at term, rupture membranes, water's clear, baby's happy, dilate up, push the baby out, fantastic. And that's all well and truly within the capability and expertise of a midwife. And you might only get a doc called if somewhere along that process things are not going well. In the private system, the patient is admitted to the private hospital under the care of the obstetrician. And so, if one of my private patients comes into labour, I'll go and see that woman, regardless of how things are going, and make a plan, let that patient know when I'll be back again, and then I don't stay there the whole time. I'm coming and going at agreed times to check on progress and to make plans and to change advice if the circumstances are changing.
I'm Kate Langbrook and I host No Filter. Celeste Barber.
Hi.
Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up, because you're always growing up with you around. So thank you.
Sally Hepworth, what an absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
And I just want to talk really briefly about the responsibility of, say, if that person had an independent midwife and the hospital midwife. Who's in charge in that circumstance?
Yeah, that can get a little tricky, which is why if someone is under the care of an independent midwife and they want that independent midwife to come with them to the hospital, then that's something that has to be arranged in advance. If that independent midwife in our system is not an accredited midwife to practice at that hospital, then if they come along, it's as a support person, but it's the hospital midwives who would be calling the shots.
Yeah. And that independent midwife, if she's had clearance and it ticked all the boxes,
yes,
she can be the person that delivers the baby?
Yes. So sometimes with an independent midwifery a model, the best independent midwife to have is someone who's also an employed midwife at that hospital.
Yeah, right.
So that they could come with you into the hospital and then become your primary midwife for the hospital part of your care.
Yeah, right.
And that would be one of the better systems, but it's not. It's a hard system to organise.
Yeah.
And it's not available everywhere.
Yeah. All right. So we talked about the main medical people actually during the labour. Are there any other non-medical people that perhaps could pop their heads in at that stage?
Yes.
There's no one taking your order for like dinner or anything, is there?
Yeah, there's the tea lady, absolutely.
Oh, yeah.
The tea person, they definitely pop in saying, do you need a cup of tea? There's various other hospital people or with a job. So there's, if you're a patient in a hospital, there's plenty of people knocking at your door for various reasons.
And Pat, I'm assuming that if it's a teaching hospital, that you might have some student doctors and student midwives.
In the Australian system, doctors are mostly taught in public hospitals, and there would be some junior doctors and doctors in training involved in your care, with acceleration of the care right up to the senior people and to the specialist if it's needed.
Yeah, rightio.
Yeah.
And so at any one stage during this actual labour, can that woman or her support person say enough? Like, is there too many people here? Student doctors no, student midwives no.
Mm-hmm.
I don't want tea. Go away.
You could put a sign on the door saying I definitely don't need a cup of tea. Don't knock for a cup of tea. And you can request that training people are not involved in your care in a public hospital in Australia. It's not always possible. Sometimes the training people, they're not only there to train, they're also part of the service provision. So, for example, registrars and residents, junior doctors in a public hospital in Australia, they're not just there to learn, they've got a distinct job to provide as well. And if you need assistance, then that's the person who's going to give it to you.
Yeah. And I think we sort of mentioned this in the birth plan, but you can ask people to use quiet voices or messages to go via the support person or whatever. Like, just have a think about how you might like that room to look.
Mm-hmm.
Good. All right. Ready to push? Does anything change? Like, are there more people in the room?
Occasionally. So at that point, we would want your midwife to be there. If you're in a private hospital under a private obstetrician, ideally the private obstetrician is there at the pushing stage. So when we're right up to the baby's nearly coming, at that point I would come and then not go away again. Wait till the baby comes. And we might at that stage have some other people involved. So, for example, if we think that the baby is in a state where it might need to come out and need some resuscitation, or we're doing an instrumental birth.
On the ward,
then we'd call the paediatrician first, okay?
Oh, yep.
No sense really calling them once the baby's out and if we need trouble because they might be 15, 20 minutes away. So we'll have them there already. If we're having problems with an epidural block, we might have the anaesthetist around. Come around, give us a top-up.
Yeah.
Inject some more local anaesthetic and make things more comfortable.
I forgot to talk about the anaesthetist earlier. Do they just come one person or is it them and an assistant?
No, just them.
Yep.
And they might have come in earlier to put an epidural in and then we might want them back towards the end to give it a top-up.
Yeah. We're talking today about who is in the room when you birth and why are they there?
Sure.
All right, so let's say the birth now needs further assistance.
Sure.
And you're going for an assisted birth. And if we can talk about maybe in the room first, in the same room, is there extra people there?
No, not necessarily at this stage. So we've got our paediatrician, we've got our obstetrician, we've got our midwife, patient and support person. That should be enough for an uncomplicated vacuum or forceps in the labour ward. Different if we go to theatre. So if we're going to go to theatre, not for Caesar, but if we're going to go to theatre because we want to do the instrumental birth in theatre, just in case it doesn't work, we want to be able to immediately do a Caesar, or if we'd prefer to be in the theatre environment for other reasons. then but there's going to be a whole bunch of extra people in the theatre.
Can I go back, and this is, again, it's a logistics episode, so how have I got to the theatre?
How do you get there?
Yeah.
Yeah, well, that's one of the extra people, so the theatre will send an orderly around. We call them orderlies or techs, and they're the people that sort of wheel you in and out of theatre. And they're also the people who know how to use all the clever gadgets in theatre.
Yeah.
They know how to switch everything on, how to boot everything up, how to start the computers up, all sorts of really quite technical expertise, as well as actually pushing the trolley.
Yeah. And I'd have to say, like, during my Caesars, the person pushing the trolley, I've had big conversations with them. So, they all are part of your care.
Absolutely.
Yeah. All right, so I've been pushed along to the theatre,
Yeah.
And it's for the assisted birth, but I could imagine it's a bit the same, is it, as a caesarean birth, or is the people in that theatre room different?
Well, no, they're the same people. So now whether we're coming around to theatre for a forceps in theatre or for a caesarean section, we have definitely got the team we talked about before. We definitely need an anaesthetist now, because we might want to put in a spinal block for either the Caesar or for a theatre instrumental. And theatre is a different environment to labour ward. So midwife is the boss in labour ward, and the boss in theatre is theatre nurses, and that's a little different because we've got the theatre nurses running the show in theatre, so in charge of checking you in and bringing you into theatre and making sure things are all kept sterile and all those sort of things. But you also want your midwife to come around from labour ward as well, because she's been looking after you all day.
And she gets all scrubbed up?
Yeah, she'll go and put on her theatre pyjamas, and then the midwife's got a role in the theatre of continuing to support you and liaising with the theatre people to make sure that goes well. Then from the moment that we start up, say, the caesarean section, then the theatre nurses do all their technical theatre things like they would for any operation. And then once baby's out, baby's handed to the midwife, and the midwife will look after the baby, give the baby a little kickstart, help the paediatrician with the resuscitation if it's necessary.
Right. And when you say theatre nurses, how many are we talking?
Well, there's always quite a few of those. So there's usually one person who's in charge. Like, let's say for a caesarean section, there'll be one scrub nurse, so that she's up at the table with me, and she's handing me the instruments.
So she's your assistant?
No, there's another.
An assistant too.
Assistant, yeah,
so there's a lot of people.
Okay, so the assistant's another doctor, and that person is helping me do the operation. And when I tie a knot, they cut the stitch, and they move instruments around so I can see what I'm doing. That's what the assistant doctor does. There's a scrub nurse, and she's in charge of sterility around the operating table, and she's handing me instruments, loading up sutures, and doing that scrub nurse job. Then there's a scout nurse who's the nurse we send out if we need something unexpected that wasn't on the original setup. So we say, can you please go and get us this stitch or this instrument? And off they go and get it. And there's the anaesthetist, and the anaesthetist will often have an assistant who's an anaesthetic nurse.
Wow. And still got orderlies in the room?
Not the whole time, but they'll be in charge of bringing you in and setting you up on the operating table. That's very important.
Oh, yeah, they're the ones that sort of bring you over onto the operating table, yeah.
Exactly. And positioning you on the operating table it's a really important job. One of the things that really makes the difference between a difficult or a really easy operation is how well the patient is positioned on the operating table. And an experienced theatre tech is there for that. Yeah,
you're sort of a bit head down, aren't you, and a bit twisted? No. From memory.
A little bit head down definitely helps. So for a caesarean section, we want to be on the operating table tilted to one side so that we're not squishing those big veins that bring blood from your legs back to your heart. And for a theatre instrumental, we might be less tilted but legs in the air.
Yeah. All right, and paediatrician. Did we mention paediatrician at a Caesar? Yeah.
Waiting to receive the baby and make sure the baby doesn't need any immediate resuscitation, providing that resuscitation if the baby does need it, and usually assisted by the midwife who's come around from the ward. Yeah.
All right. That sounds like a lot, and it is a lot, and it does feel busy.
But it feels busy, that's right, yeah.
But it feels with purpose. Like everybody's moving around with purpose.
Yeah.
And even if anyone's in that situation and they might think, oh my God, why is there so many people here, and does that mean that this is going that pear-shaped? No, everybody's just got a job.
Yes, and it doesn't mean it's going pear-shaped at all. In fact, having all of those people well trained for their job means that it doesn't go pear-shaped.
Yeah.
To the patient, I get that it can feel that way, but people often report in an emergency or even a sort of a semi-urgent situation how impressed they are that the team works so well together.
Yeah. My advice is really look at your midwife's eyes, because once they've got a mask on, it's a bit hard to tell.
Find them.
Yeah,
who's who.
Yeah, but
good.
Hopefully they've come and introduced themselves to you. Yeah,
that's a good point. I'm going through that in the consulting at the moment, because I'm looking after lots of people who are still pregnant. For the first 2/3 of their pregnancy, we had masks in the rooms.
Yeah.
So I still don't know what everyone looks like with a mask on.
Yeah. That's right. Good. All right. So we've come back after the cesarean, and in the recovery ward.
Oh, we didn't do who's coming from the support people into the theatre.
Yeah.
So you might have 2 support people in labour ward, but give or take, there's usually only 1 support person in the theatre.
Yeah, rightio.
I've had a few exemptions granted to that over the years in some special situations.
Yeah.
But usually that's a key. That's your key support person who's coming to theatre, and that's something you should work out beforehand.
Oh, definitely.
Extra people in theatre can be extra risk of infection and so forth. So usually the rule is 1.
Yeah.
Yeah. So if your mum and your husband are coming to the birth better workout, who's coming to theatre if you need to go to theatre?
Or the tricky decision between your doula and your partner.
No, yeah, well, yeah, there's
all of that. You can just make those decisions.
Mm-hmm.
And just so they know, they get all in their gear too, don't
yes.
they? What do they do? They get a hat and theatre scrubs?
The theatre scrubs, yeah.
And it's normally the tech that helps them out there.
That's right.
Yeah.
So tech will take the dads around to theatre and get them kitted out.
Yeah, good. All right, so then you go into the recovery room.
Yes.
If you've gone to theatre, this is. Recovery room, and you've got your midwife.
Yeah.
And
recovery
nurse.
Recovery room nurse, whose job it is to keep a close eye on your observations and make sure that after you've had an operation like a cesarean section that your heart rate, respiratory rate, blood pressure, urine output, it's all normal. And then you'll be together with your partner and your baby. And we pride ourselves on being able to do that practically every time. Okay, so sometimes a sick baby will need to go straight up to the nursery, but assuming that everything goes fine and the baby's not sick, then we want to keep the family unit together. Yeah, with your support people. So you're not really apart at all. You can go as a family round to the recovery room, stay in the recovery room as a family, in our general hospital, the recovery room's full of people who've had all sorts of other operations. So we've got a little, a curtained off area just for someone who's not sick. They've just had a cesarean section, and it's a little bit separate from all of the people who've had a gallbladder and a bowel operation and a broken leg and all the other things in the other recovery bays. And
your midwife might be there, and you might start trying breastfeeding if that's what you're choosing to do.
Absolutely. So it's business as usual. There we get skin contact, baby on the breast. Start that. All of that motherhood starts right there and then.
Yay!
Yeah.
Oh my God, little buzz. And I just want to ask if you've had an assisted birth in theatre, do you still go to the recovery?
Yeah, you got to go recovery. You're likely to have had a spinal anaesthetic. We're in the theatre environment, and that so ran a recovery for a bit.
Yep.
Do the usual recovery things, and then back to the labour ward when it seems appropriate, and then from the labour ward out to a postnatal room, once everything's stable and good.
Yep. And you could stay there anywhere between maybe 24 hours and 5 days, depending on whether you've had a vaginal birth or a cesarean.
Yep.
So the people that you're going to see is going to be varied.
Yeah.
But there's quite a few people that
might come in.
Yeah.
Yep. Good.
So you have lots of midwives that come.
Midwives will come in and they'll change on a shift basis.
Yeah.
If you've got a private obstetrician, that person will come once a day see you and deal with any issues that come up. And hospitals are busy places.
Yeah. Are they all midwives in the postnatal ward, or are some like ward nurses?
No, they're usually midwives.
Yeah.
In Australia, they're usually midwives. But the hospital's a busy place. There's the guy selling the newspapers and the tea person and the people who bring around the meals and a cleaner and it's one of the many reasons why it's a good idea to go home.
Yeah.
When safe.
Yeah, and if you get your little tick the box, what do you want to eat? Just do it there and then, and so then you can give it back, and nobody comes again and saying, "Have you done that yet?" And you go, "No, I haven't." Have you done that yet?
You have to be
an
organised consumer of healthcare, so that get it all done, and because you also want some sleep.
Yeah, and I'm not sure this is the same in everywhere in the world, but here in Australia, you also have a visit from the audiologist.
Yes.
To do the newborn hearing test.
Yes.
And you get a visit from the physiotherapist to
kickstart your physiotherapy. Yep. Yeah. So newborn hearing screening is very important. We want to pick up babies with hearing problems straight away. The hospital physio visit is important, but not to be confused with the importance of going to see a physiotherapist after 6 weeks. I think that's where the real benefit is. There's too much going on mentally and physically right at the start, I think, to take much of it in. But if you go back to the physio after 6 weeks, to a private women's physio or to a community physio facility, you've got a chance of taking it in and learning a good technique for pelvic floor exercises that'll see you in good stead for the rest of your life.
Yeah, that's a good tip, Patty. And does every baby need a paediatrician check before they're discharged?
No, in our hospitals we have baby checks. Every baby should be checked before discharge. So
by a paediatrician?
No, by a skilled person. So that might be a midwife, might be a junior doctor, might be a junior paediatrician, might be a consultant paediatrician, depends what's going on.
Yeah, rightio.
Yeah.
I think in the States you definitely have to have a paediatrician's tick of approval. But I could be wrong. So if you're listening from the States, just DM us and tell us whether I've got that wrong or right.
Sure.
And it's a bit like the same thing about labouring at home. You do have to have a plan for your family and friends, and if you've got other children, who do you want to visit?
Yeah, and when.
Yeah, because that makes the room pretty busy too.
Yeah. The COVID pandemic has really changed the nature of coming to see people in hospital. It's changed it from a rite of passage, something that was normal and pretty much always done, to something that's kind of only done in discussion with the family and by permission from the family.
Yeah.
And I think that's probably a good thing.
Yeah.
So the labour ward is quieter, and it still is.
Wow.
Even all this time later. Because fewer people are considering it a reasonable thing to do, to come and visit their friends in hospital and bring their own kids. And certainly they're not doing it much without asking permission.
Yeah.
But that used to be different.
Yeah. And what a great way for someone to feel comfortable about doing something as tricky for some women as breastfeeding. To have that time and to have the midwives there instead of saying, "Oh, I'm sorry, could you please come back? My family's here."
Yeah. It might just be a phase, but I'm seeing a lot more people saying, "No, we're having visitors when we get home."
All right, Pat. So this episode was really aimed at demystifying, the workings of a hospital, which I know you've got totally nailed, but a lot of people that it's a baffling ordeal.
It can be a little baffling.
Yeah. All right. So let's move on to the myth or fact.
Myth or fact?
If you're induced, the pain in labour is worse. Myth or fact?
This is a maybe.
Yeah, right.
Yeah. The strong contractions that get the cervix dilated and the baby out are going to be painful. If you are induced with a syntocinon drip, the painful ones will come more quickly than, for example, if you broke your waters spontaneously at term and waited 10, 12, 20 hours for the contractions to come. So in the 10, 12, 20 hour system, they'll creep up. Whereas if we've decided for whatever reason in discussion with the patient that the best thing to do is to use a syntocinon drip, then they'll creep up much more quickly. So people often think that the pain's going to be worse. I'm not sure that it's worse. It'll just come quicker.
Yeah, without nice breaks in between or breaks to recover in between? Or do you still get those breaks?
No, we're supposed to use the synto in a way that gives the baby plenty of breaks in between to recover. No, I just mean in between starting the drip and regular painful contractions coming, that's going to be less time than if that all happens naturally. Is the pain worse? I don't think so. I think it just comes on you faster.
Why don't they, when they give the synto, give a little bit of an injection of endorphins at the same time?
I don't know. I don't think that's a thing.
Again, that's why I'm not the doctor.
And sometimes I think that the high levels of intervention that's sometimes called the cascade of intervention probably happens because we don't get a chance for painful contractions to creep up slowly and to slowly adapt to it. We give Syntocinon because we want to get things moving faster, and it works. They do move faster, and it really hurts.
Yeah.
And we might reach for some stronger levels of pain relief in those settings.
You heard it here. That's a maybe.
Yeah, confirm maybe.
Thanks for listening, everyone. We really appreciate your love and support, and we love being here, just sharing our knowledge. So if you've got any questions, just you can jump on the speak pipe. We're getting some really great questions through there, so we should do a Q&A soon. So you can just find that on our Grow My Baby website. So that's www.growmybaby.com.au. All right, until next week, we'll see you then.
See you then, everybody.
Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.